here, and good evening, all of you. And how is the preparation going on? How is the preparation going on? Okay, how is the preparation going on? How is the preparation going on?
I believe we are. I thought we were not.
Okay, great. All right. So this is, so welcome everyone, and good evening. And you've had these must-know sessions, and I was looking forward to must-know physiology session because this is extremely important. Physiology, high yield, know these important topics in physiology. I can assure you, you will do very well in physio. All right. Yes. Okay. So let's go on to the must-know topics. The first thing that I have to, a little bit of gyan has to be there from your teachers, isn't it? And revision. Please go through your class notes. That is what I keep insisting on, and that is what all teachers are insisting on. That revision is the key. That's the only way to retain all this information. Know what you know. Whatever you have done, know it well. You have to just listen to me. That's more than enough. You can go through these videos later, right? Okay. Know what you know. Whatever you know, you must know it really well. So keep revising. That is the only key. Use line diagrams to understand a particular concept. When you're reading something, write down whatever is written in your notes. Write it in a form of a line diagram. Okay. Topic-wise integration, physio, pharma, medicine. This is important in four or five systems, and that is CVS, respi, renal, endo, and CNS. Try and do it in topic-wise manner, especially in these five systems. Stay positive. That is absolutely important. Don't worry about how bad things are or what is happening around you. Just be positive. You will do well. You have been studying. You will do well in this exam as well. Do not bother looking at any new material at this stage. Not required. Absolutely not required. You've got more than enough. Whatever you have, keep revising that. Weed out all the negative people in your life. And I do not mean the weed out. I mean actually get rid of all the negative people in your life. Not required. You cannot handle all this at this time. Okay, say take regular breaks and sleep well. 6 to 7 hours is a must. So let's go on to the physiology topics, and this is the first thing. Of course, I'll start off with basic concepts. And basic concepts, the first one that you have to know very well is the distribution of total body water. This is such an important topic, has been asked so many times. You have to know that 2/3 is in the ICF, 1/3 is in the ECF. You have to know that the ECF in turn consists of plasma and interstitial fluid and the transcellular fluids. Theoretically a part of ECF, but when you're measuring the ECF, you cannot measure the transcellular fluids. So distribution of total body water, this is asked in different ways. There was a recent question, and that said 75% of ECF is in which space? And you should be able to say the interstitial fluid. Plasma is 5% of body weight. Interstitial fluid is 15% of body weight. So 75% of the ECF is in the interstitial space. So plenty of questions from the distribution of total body water. For the measurement of different body fluid compartments, remember the formula V is equal to Q minus E over C, isn't it? That is, Q is the known quantity of the indicator which is used, indicator or the dye. E is the amount which is metabolized or excreted during the procedure, and C is the concentration of the dye in a sample withdrawn after mixing has taken place. Okay, all right. Let's see, cell membrane, the lipid bilayer. You've got the hydrophilic heads towards the ECF and ICF, and the hydrophobic tails towards the inside. Remember the proteins which are present in the cell membrane, the different types of proteins. What are the functions of the proteins? Proteins, firstly, protein and lipid ratio 1:1. What are the different types of proteins? These proteins are, they can be transport proteins, they can be channel proteins, they can be structural proteins, they can be receptors, they can be antigens. So different functions of the receptor proteins, they can be antigens, they can be enzymes. So different functions of the proteins. And remember, what is in terms of the dry weight of the cell membrane, the proteins and lipid ratio is 1:1, though the percentage of proteins is 55% of the dry weight of the cell membrane, right? So this is the basics you have to remember here. These are all given in your notes, but I'm highlighting the questions which have been asked in the last few years. Gap junctions is one important topic. Gap junctions made of connexins. Yes, connexins, each connexin has got these 6 subunits, right? 6 subunits which surround a central pore, right? Though, of course, earlier in the NEET exam, you have been asked the diameter of the central pore. Yes, the diameter of a connexin is 2 nanometers and the diameter of the central pore is 0.8 to 1.4 nanometers. But of course, I do not expect value-based questions in this year, but definitely this is something which you must know. What are gap junctions? What are they made of? Connexins. And which are the tissues which have got gap junctions? The gap junctions are seen in the cardiac muscle, in the single unit type of smooth muscle, retina. These are the areas where you get gap junctions. Gap junctions will permit the movement of substances up to 1000 Daltons between the cells. It's a bidirectional transport through gap junctions. Gap junctions form electrical synapses. Question has been asked. Electrical synapses are formed by, this was a NEET question, this is formed by connexins. And if you remember, the mutation of connexins gives rise to a clinical condition which is known as the Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease. Remember, electrical synapses, these are going to form electrical synapses. Like I said, this question has been asked. Gap junctions is another favorite topic. The transport across cell membrane, you have a passive transport. There is the simple diffusion, facilitated diffusion. There is a non-ionic diffusion. And there is osmosis. These are passive. Passive means they are not going to use energy. No energy is required. Passive means it is along an electrochemical gradient, as well as a concentration gradient. And for simple diffusion, one important law that you have to remember, and that is called the Fick's law of diffusion. Fick's law of diffusion. And what is the Fick's law of diffusion? That says J is equal to minus dA delta C by delta X. J is equal to minus dA delta C by delta X. And D is the diffusion coefficient, which is unique for every substance. Diffusion coefficient depends upon the lipid solubility of that substance, directly proportional to the lipid solubility, inverse to the molecular diameter, and inverse to the molecular weight, but inverse to the square root of molecular weight. This has been asked as an old NEET question. The most important factor which determines the movement of a substance against a substance through the cell membrane is the lipid solubility of that substance. And number 2 is molecular diameter, and number 3 is the molecular weight. A is the surface area, more the surface area, more the rate of transport. Delta C is the concentration gradient. More the gradient, more the rate of transport. What is delta X? Delta X is the thickness of membrane, or in some questions, it is written as the diffusion distance. Please be careful. If it does not say thickness of membrane, it says diffusion distance. It means the same thing, right? Transport will be inverse to the diffusion distance or inverse to the thickness of the membrane. More the diffusion distance, less will be the rate of transport. This is simple diffusion. What happens in facilitated diffusion? It's a passive transport, does not require energy, but it requires the presence of a carrier protein. And when there is a carrier protein which is present, what will happen to the rate of transport? There is going to be a TM in facilitated diffusion, a transport maxima. There is a maximum rate of transport in facilitated diffusion because of saturation of the carrier protein. If you look at the simple diffusion, it's a linear relationship. More the gradient, more the rate of transport. But in facilitated diffusion, more the gradient, more the rate of transport, till it reaches a TM, transport maxima. Why so? Because like I said, this is the carrier protein can get saturated. Non-ionic diffusion, very specific non-ionic diffusion in the collecting duct, secretion of ammonia, excretion of weak acids and weak bases in the kidney, absorption of weak acids in the GI tract, for example, salicylates in the stomach or bile acids in the distal ileum. This is non-ionic diffusion. Osmosis, movement of water. What about active transport? Primary active, secondary active. Primary active requires energy. Secondary active depends on primary. Secondary active is linked with sodium. It can be co-transport, it can be counter-transport. You must know your sodium-potassium pump well, right? Sodium-potassium pump well. I read something very interesting. Somebody had put up yesterday कि आजकल दिमाग is like a sodium-potassium pump. 2 टॉपिक अंदर आते हैं, 3 टॉपिक बाहर जाते हैं. 3 sodium move out of the cell, 2 potassium move into the cell. So आजकल this is the halat. So remember your sodium potassium pump. This is extremely important. Lot of questions which are asked. I've already given you point wise in your notes. You must know what is the coupling ratio of sodium potassium pump, 3:2. You must know that it is a heterodimer, though I must tell you that latest research is saying that there are 3 subunits in the sodium potassium pump. There is a alpha, beta, gamma. Role of gamma is uncertain. Right? But as far as we are concerned, what is accepted? So for a NEET exam, please go with heterodimer. Though, like I said, there are research articles which are saying there may be a 3rd subunit, but that is not accepted as yet. That's not the standard as yet. So we will stick with heterodimer. Do not get confused if someone says that. All right. The next is nerve physiology. Now, as far as nerve physiology is concerned, before the first important concept which you have to understand, though that's a part of general physiology, you must remember your Gibbs-Donnan equation. What is the Gibbs-Donnan equation? Gibbs-Donnan equation gives you the distribution of a pair of diffusible ions. It gives you the relationship between a pair of diffusible ions at equilibrium. When these diffusible ions are in 2 compartments separated by a semi-permeable membrane with proteins on one side of the semi-permeable membrane. So what is this? What does this Gibbs-Donnan equation? This tells you that the ratio of K plus in X and K plus in Y will be equal to the ratio of Cl minus in Y and Cl minus in X, right? So the Gibbs-Donnan equation. And remember, this is at equilibrium. What is equilibrium? When there is no net transport. No net transport, right? Then another equation which you have to remember is the Nernst equation. Now remember, Nernst equation gives us the magnitude of the equilibrium potential. This gives us the magnitude of the equilibrium potential, right? Equilibrium potential. And so the one important point as far as Nernst equation is concerned is that the cell membrane has to be freely permeable to that particular ion. Yes, cell membrane has to be freely permeable. When the cell membrane is freely permeable, movement of the ion will occur from higher to lower concentration, leading to a potential difference leading to creation of a potential difference. And this potential difference, the magnitude of this potential difference at equilibrium is calculated by the Nernst equation, right? Then the Goldman-Hodgkin-Katz equation. Goldman-Hodgkin-Katz equation. This is used for the calculation of Goldman-Hodgkin-Katz equation. This is used for the calculation of the resting membrane potential. Resting membrane potential. Now, in the Goldman-Hodgkin-Katz equation, we take into consideration not just the concentration gradient of the three major ions, but also the cell membrane permeability for the three major ions. Right? So these are three important equations that you have to keep in mind. Gibbs-Donnan, Nernst equation, Goldman-Hodgkin. Gibbs-Donnan gives us the relationship. It gives us the mathematical relationship between a pair of ions at equilibrium in two compartments separated by a semi-permeable membrane with proteins on one side. Nernst equation gives us the magnitude of equilibrium potential for an ion when the cell membrane is freely permeable to that ion. And Goldman-Hodgkin-Katz equation will give us the value of the resting membrane potential in millivolts. And for this, the concentration gradient of the three major ions as well as the cell membrane permeability for these ions will be taken into consideration. Now, the next important point, this is one graph which I want you to focus on. Though this graph has been asked in the AIMS exam, but you know, offshoots of this graph has been, or questions arising from this graph have been asked in the NEET exam. The diagram, image-based question, AIMS exam, but questions from this particular diagram have been asked in the NEET exam. So if you look at this, the one in the dashed line are the potential changes. Potential changes. This is the action potential. And this is showing you the conductance of sodium, and this graph is showing you the conductance of potassium. So what is responsible in the depolarization phase? Because of opening of voltage-gated sodium channels by a positive feedback mechanism, there is a sudden influx of sodium and there is a sudden rise in the conductance of sodium. Sharp increase in the conductance of sodium, which gives rise to the depolarization phase of the action potential. Voltage-gated sodium channels are fast channels, fast to open, fast to close. They begin to close, and that is responsible. They begin to close. They are responsible for the repolarization phase. So repolarization phase is because of, this is the repolarization phase, which is because of closure of sodium and opening of potassium. Closure of sodium and opening of potassium. Right? And then you see this is the potassium channel which is opening up. Sodium is closing, so the sodium conductance reduces, potassium conductance increases. Then the slow closure of the potassium channels is what is responsible for the hyperpolarization phase. Right? There is a slight decrease in the rate of potassium efflux towards there's a slight decrease in the rate of potassium efflux, which gives rise to the after depolarization phase, right? After depolarization phase. So please pay attention to this graph. You've got the changes in potential superimposed on the changes in membrane conductance for sodium and potassium. Extremely important graph. We've done this in class notes. It's there in your class notes. Go through that. Go through the differences between voltage-gated sodium and potassium channels. What is refractory period? Another important topic in this, in physiology, refractory period, absolute refractory period, which extends from firing level till repolarization is 1/3 complete. Relative refractory period from repolarization 1/3 complete till the start of after depolarization. In the absolute refractory period, no response. Give another stimulus. There will be absolutely no chance of a response irrespective of the strength of stimulus. Relative refractory period, you can get a response if the strength of stimulus is increased. So this is as far as your hyperpolarization. Imtiaz hyperpolarization is here. This is -71 to -72 millivolts. That is when the potential goes 1 to 2 millivolts below the resting membrane potential. Resting membrane potential is -70, and because of slow closure of the potassium channels, there is the potential of the cell goes 1 to 2 millivolts below the resting membrane potential, right? Okay. Let's see this. As far as muscle physiology is concerned, yes, we will put up a PDF, Pranoti. Don't worry, there will be a PDF for you. Listen to me right now. Keep your notes open in front of you. That is the best way to go through all these important topics, right? And don't worry, you will get an uploaded. The PDF will be uploaded. Now, as far as muscle physiology is concerned, I would like you to focus on transmission across neuromuscular junction. You must know that the neuromuscular junction is between the A-alpha motor neuron and the sarcolemma. Please be very careful. This is the muscle fiber which is equal to the muscle cell, and muscle fiber is made of myofibrils. Myofibrils are made of sarcomeres. Sarcomere is the structural and the functional unit of the skeletal muscle. The cell membrane of the muscle fiber is known as the sarcolemma, and the part of the muscle fiber which forms the junction with the A-alpha motor neuron, this part is going to be thickened to form what is known as the motor end plate. Now, motor end plate has the acetylcholine receptors. Acetylcholine receptors, and what are these acetylcholine receptors? Again, important question. Ligand-gated sodium and potassium channels. But the movement of sodium through these channels predominates. So though they are both sodium and potassium channels, but the inward movement of sodium will predominate. That leads to a depolarization and what is known as the motor end plate potential. Please, important point, do not get confused. This has been asked. The motor end plate potential at the motor end plate is a local potential. This is due to ligand-gated sodium and potassium channels. It is due to the inward movement of sodium predominantly, which is responsible for this motor end plate potential. Now, these motor end plate potentials will summate, and an action potential is generated, and that action potential spreads all over the muscle fiber membrane and enters into the T-tubule. What is the T-tubule? T-tubule is formed by the invagination of the sarcolemma. And what is the advantage of the T-tubule? Now, this invagination of the sarcolemma ensures a very rapid spread of impulses to the interior of the muscle fiber. This helps the myofibrils to contract in a synchronous fashion. Very rapid spread of impulses to the interior of the muscle fiber. One small point, these action potentials which are going to travel all over the muscle fiber membrane, these action potentials are due to voltage-gated sodium and potassium channels, not ligand-gated. Please keep this in mind. The action potentials will be due to voltage-gated, the one which are being transmitted which are traveling all over the muscle fiber membrane to enter into the T-tubule. Where are the ligand-gated channels located? They are limited to the motor end plate, right? And what is the receptor which is present here? The receptor which is present here is a dihydropyridine receptor. There is a mechanical coupling with the ryanodine receptor. Where is the ryanodine receptor, this is on the L-tubule or the sarcoplasmic reticulum. As soon as the action potential reaches dihydropyridine receptor, it is a voltage sensor. There is a conformational change, mechanical coupling with the ryanodine receptor, opens the ryanodine receptor, calcium will come out of the sarcoplasmic reticulum, bind with troponin C. There is a conformational change in troponin, tropomyosin slides, actin-myosin interaction starts, muscle contraction starts, right? So this is important as far as your muscle physiology is concerned. When I say excitation-contraction coupling is this, right? Action potential reaching the dihydropyridine receptor, conformational change of dihydropyridine receptor, mechanical coupling with ryanodine, release of calcium. This is called excitation-contraction coupling. You must know the applied parts, the clinical parts relevant to this: disease of the presynaptic membrane, Lambert-Eaton syndrome, postsynaptic membrane, myasthenia gravis, ryanodine receptor, mutation gives rise to malignant hyperthermia. Let's see, this actin-myosin cross-bridge cycling, we have done it in class. Sequence is extremely important. If I start with the power stroke here, next is ATP attaches to the myosin head, leading to a detachment, recocking of myosin head. If calcium is available, it will bind with the next, it should have been hydrolysis of ATP and then the recocking of the myosin head. Okay? Yes, Shiv Sai Chaitanya, ryanodine receptors are also ligand-gated channels. What is the natural ligand for the ryanodine receptor is calcium. Though it is called a ryanodine receptor because ryanodine, if we inject, binds to these ryanodine receptors, and that can be used to identify these receptors. But the natural ligand for the ryanodine receptor is calcium, right? Okay. Preloaded, afterloaded skeletal muscle contractions are important. Preloaded means the load is acting on the muscle at rest, which increases the initial length of the muscle. It stretches the muscle. And preloaded muscle contractions are much more efficient as compared to the afterloaded muscle contractions. Right? Preloaded are much more efficient. They have a shorter latent period, longer contraction period, longer relaxation period, more height of contraction, more work done in preloaded states. Preloaded states are much more efficient as compared to afterloaded state. Now, as far as cardiovascular system is concerned, you must know the differences in the sarcotubular system of the skeletal muscle and the cardiac muscle. We do this in class when I tell you that the the T-tubule in the skeletal muscle, the T-tubule is at AI junction, but in the cardiac muscle, it is at the Z line. Much wider T-tubule in the case of this cardiac muscle. Less well-developed sarcoplasmic reticulum in the case of the cardiac muscle. The dihydropyridine receptor is a voltage-gated channel in cardiac muscle. Ryanodine receptor is there is going to be movement of calcium from the ECF to ICF. This only happens in cardiac muscle. What is the source of calcium in skeletal muscle? Important question. Only sarcoplasmic reticulum. But in the case of cardiac muscle, it is mainly the ECF and also the sarcoplasmic reticulum. Now, entry of calcium causes release of more calcium from the ryanodine receptor, and this calcium will bind with troponin C and muscle contraction will take place. For a muscle relaxation, the calcium has to go back into the sarcoplasmic reticulum, which is done with the help of a primary active transport in both skeletal and cardiac muscle, that is SERCA. But in the cardiac muscle, you have another mechanism where there is a sodium calcium antiport. This is obviously not seen in skeletal muscle. Source of calcium in cardiac is ECF and sarcoplasmic reticulum, but mainly the ECF. One more point about cardiac muscle is the presence of an inhibitory protein asked as a question, and that inhibitory protein is called phospholamban. This inhibitory protein inhibits SERCA activity. When I inhibit this inhibitory protein, SERCA activity will increase, producing a faster relaxation. What causes inhibition of this inhibitory protein is sympathetic discharge. Sympathetic discharge will also, besides being positively inotropic, chronotropic, dromotropic, bathmotropic, sympathetic discharge is also positively lucitropic. What is this lucitropy? It inhibits phospholamban, increases SERCA activity, faster relaxation. Right? Okay. Now, SARICA, dihydropyridine receptor, ryanodine receptor. This is, in the case of the skeletal muscle, as soon as the action potential reaches dihydropyridine receptor, there is a conformational change of dihydropyridine receptor. Between the dihydro and the ryanodine is a mechanical coupling which opens the ryanodine receptor. Right? So it is electrical followed by mechanical coupling. If you have to choose between electrical and mechanical, please go ahead and say mechanical coupling between these two receptors. But if there is an option which says electrical followed by mechanical, that seems to be a better option. Ryanodine receptor is also a ligand-gated calcium channel, Bhashya. It's a ligand-gated calcium channel in both skeletal and cardiac muscle. Okay? All right. Plateau potential, this is extremely important. What is the plateau potential? Which are the cells which are going to show you the plateau potential? Especially the contractile cells of the heart, as well as the conducting cells of the heart, except SA node, AV node. All other parts of the heart, contractile as well as conducting cells, will show the plateau potential. 5 phases. This is phase 0, phase 1, phase 2, phase 3, phase 4. Phase 0, because of sodium influx. Phase 1, closure of sodium, opening of potassium channels. Phase 2, calcium, along with potassium efflux, there is a calcium influx. Through which channels? These are called the slow calcium channels. Yes, phase 3, potassium efflux, and phase 4, hyperpolarization phase. What is the advantage of the plateau? Advantage of plateau, again a question which has been asked. Advantage of plateau, prolonged refractory period. Heart muscle cannot be tetanized because of this prolonged refractory period. In the case of skeletal muscle can be tetanized, but not the cardiac muscle. And what is causing this prolonged refractory period is the plateau phase. Plateau phase because of calcium influx, right? Then the pacemaker potential. Now, as far as pacemaker potential is concerned, you've got a phase. Firstly, the RMP is the RMP in the case of the pacemaker potential is between -60 and -50 millivolts, generally about -55. You have a phase 0, phase 3, phase 4. There is no phase 1 and 2. Important point, the phase 0 or the depolarization phase is because of a calcium influx, not sodium. This is because of a calcium influx through what are called the calcium L channels. Phase 3 is potassium efflux. Phase 4, which is known as the prepotential phase, this has got 3 reasons. Number 1, decrease in potassium efflux. Number 2, the opening of the funny channel, which permits the movement of both sodium and potassium, but mainly the movement of sodium. And number 3, calcium influx through calcium T channels. Right? Okay, so this is another important diagram. This is given in your CRS. We discuss about this in class mainly to tell you what is the nodal delay. This is another question which has been asked frequently. Nodal delay, the duration of nodal delay is 92 milliseconds or 0.09 seconds. Reasons for nodal delay. AV node fibers are small diameter fibers with very few or no gap junctions. Has been asked, what is the reason for nodal delay? Small diameter fibers. Advantage of nodal delay. Atria contract ahead of the ventricles. What is the sequence of ventricular depolarization? Sequence of ventricular depolarization is septum, endocardium, epicardium. Septum, endo, epi. This is the sequence of ventricular depolarization. In ventricular repolarization, the direction reverses. Repolarization is epi to endo. The first part of the ventricle to repolarize is the apex epicardium. Last to repolarize is base endocardium. Now, this is such a favorite topic. So many questions are being asked from the cardiac cycle. And one little way to remember what follows what, because those are the most often asked questions. Even NEET of last year had a question on the cardiac cycle. Now, this is between first heart sound, second heart sound, you've got ventricular systole. Between second and the next first heart sound is ventricular diastole. Just to remember, if you're recording these 3 things simultaneously, ECG, heart sounds, JVP, the aortic pressure curve and the JVP simultaneously, what follows what? One little formula here. P wave is P wave followed by A wave followed by Q wave of P wave followed by A wave followed by Q wave followed by R followed by first heart sound. PAQR 1. PAQR1, then C wave of JVP in the isovolumetric contraction phase, then the X descent of JVP in the ejection phase. Then the second heart sound. Second heart sound also coincides with the incisura or the dicrotic notch, followed by the V wave of JVP, followed by third heart sound. Third heart sound coincides with the Y descent. S4 will coincide with the A wave if S4 can be heard. So if you remember this little formula which I have made for you, though I don't have a mnemonic for this, in case you can come up with a good mnemonic, you can let me know as well. This is PAQR1CX2V3. Remember this, you should be able to answer a lot of your questions. Questions like, which phase of JVP coincides with the third heart sound? Y descent. Second heart, the incisura coincides with which heart sound? Second heart sound. The V wave, the second heart sound is with the V wave, before the V wave, after the V wave. Second heart sound is just before the V wave. Just before the V wave, right? So another one, you were asked sequence. You were asked first heart sound is with the R or after the R. It is just after the peak of R. Just after the peak of R. So PAQR 1CX2V3. All right, PAQR1C. You can add X as well. Though I don't usually talk about X because X is a negative wave of the JVP, but you can add X because X coincides with the ejection phase. With the ejection phase. Shubhamon, you can add the X. PAQR1CX2V3. Absolutely right. PAQR1 COX2V3. Okay. Okay, Sneha, thank you. At least something is better than nothing, right? Okay. Pressure volume loop. Of course, this is more important for INI-CET, not so much for NEET, but you just can't predict anything these days. So at least a basic knowledge about the pressure volume loop you must know. And one A to B. A to B is isovolumetric contraction phase, B to C ejection phase, C to D is isovolumetric relaxation phase, and the D to A is the filling phase. Width of the loop will coincide with stroke volume. Height of the loop will coincide with the systolic blood pressure. Point V coincides with the diastolic blood pressure, and this is the pulse pressure. And my favorite mnemonic, Mam Coco. Mam Coco, at point A, mitral valve closes. At point B, aortic valve opens. At point C, aortic valve closes. At point D, mitral valve opens. But you have to remember, where is A, B, C, D? Fair enough? Okay, yes, absolutely right. This is this is one diagram. Which are the elastic vessels? Wind-Kessel vessels. This is very popular question with NEET exam. It has been asked in your NEET exam, and that is aorta and the large arteries are known as the Wind-Kessel vessels. These are your elastic arteries. Resistance vessels are the arterioles. Capillaries are the exchange vessels. Venules, veins, and vena cava are your capacitance vessels. The capacitance vessels, right? So this is as far as your systemic circulation is concerned. Yes, already, ma'am. Coco, good. Okay, so these are your different vessels. You have Wind-Kessel vessels, aorta and the large arteries. You've got the resistance vessels, which are the arterioles, which are capillaries are your exchange vessels. Venules, veins, and vena cava are your capacitance vessels. The fifth category are the shunt vessels, which are limited to a few areas, which also have a sympathetic supply, but they are meant for temperature regulation. All blood vessels have a sympathetic supply except capillaries. Capillaries lack a sympathetic supply. One point which I want you to focus on in this diagram, which I've deliberately put over here, sharpest fall in pressure. Sharpest fall in pressure is at the level of arterioles. Why so? Because they have the maximum resistance to flow. So sharpest fall in arterial pressure will be at the level of arterioles. Arterioles also have the least volume of blood. Less than 1% of the total volume of blood is present in all the arterioles of the body, simply because they are your resistance vessels. Maximum blood, 2/3 of the blood volume, will be present on the venous side of the circulation. Venous side of the circulation, right? So this is as far as your different blood vessels in this cardiovascular system. Baroreceptor control are absolutely important, imperative. This is mandatory. You have to know your baroreceptors. Whenever there is an increase in the mean arterial pressure, this will increase the stretch of the vessel wall. Baroreceptors are your stretch receptors. More will be the firing rate of the baroreceptors. Baroreceptors take impulses to the medulla, and response is a decrease in sympathetic and increase in parasympathetic. More the firing rate of the baroreceptors, less the sympathetic discharge. Less the firing rate of baroreceptors, more the sympathetic discharge. Please remember, this is an extremely important part. Lot of questions will be asked. Can be asked, clinical, applied, plenty of questions from baroreceptors. Threshold for baroreceptor activity is a mean arterial pressure of 50 millimeters of mercury. Maximum activation will be at 200 millimeters of mercury. Important threshold for activation is 50. Older knowledge says 60, but now we know it is 50. So in normal individuals with a normal mean arterial pressure of 100, there is a basal level of baroreceptor activity. Increase the blood pressure from more than 100, there will be increase in baroreceptor activation. Falls less than 100, decrease in baroreceptor activation. If there is a fall in the blood pressure, less is the stretch, less is the firing rate, more will be the sympathetic discharge. Effect on sympathetic is ulta. More firing rate of baroreceptors, less sympathetic discharge. Less firing rate of baroreceptors, more will be the sympathetic discharge, which is definitely a much more important, out of the two, out of carotid sinus and baroreceptor and aortic arch baroreceptors, carotid sinus, 5 times more sensitive. 5 times more sensitive, right? So this is baroreceptor control of arterial pressure. Absolutely imperative. You have to know this very well. This is something which you must go through. Renin-angiotensin-aldosterone system, renin acting. What is going to increase the renin discharge is hypovolemia, hemorrhage, hypotension, dehydration, decrease in renal afferent arteriolar pressure. Renin will increase from the JG cells. This will act on angiotensin-O-gen, angiotensin-1, angiotensin-2. Angiotensin-2 is such a powerful vasoconstrictor and also increases aldosterone. So renin-angiotensin has to be, again, you have to be thorough with it, right? So the atrial stretch receptor response, remember atrial stretch receptors they are stretch receptors, but they are not pressure receptors. They are volume receptors. They are present in the low pressure zones, atria and pulmonary vessels, low pressure zones. So whenever there is increase in blood volume, it will increase in blood volume. It will stimulate the atrial stretch receptors, and atrial stretch receptors, when they are stimulated, this will increase the ANP, decrease ADH. There will be natriuresis and diuresis to bring the ECF volume back to normal. Also, there is a vasodilation, peripheral vasodilation, and an increase in heart rate. Why is there an increase in heart rate? Because the atrial stretch receptors inhibit the vagal action on SA node. Atrial stretch receptors increasing heart rate is also known as the Bainbridge reflex. Right? Sudden increase in blood volume increases the heart rate. That is the Bainbridge reflex, mainly because of the atrial stretch receptor response. Other influences in vasomotor center. Vasomotor center, when we talk about, is the rostral, ventral, lateral medulla, or the pressor area. This is the one which controls the sympathetic discharge. What can affect the vasomotor center is chemoreceptors. Chemoreceptors. And when do the chemoreceptors get excited? Whenever there is decrease in PO2, increase in PCO2, increase in H+. Right? Brain can cortex can send excitatory impulses to the vasomotor center. Hypothalamus can send, right? Hypothalamus, limbic system, joint proprioceptors, limbic system, joint proprioceptors. When do the joint proprioceptors get excited? When you are exercising, right? Pain afferents, pain fibers, they can send impulses to the vasomotor center via the hypothalamus, increasing the sympathetic discharge. Limbic system, emotions, and when you are very scared or when you are watching a match, increase in heart rate, Joint proprioceptors, when you're exercising, increase in heart rate, increase in blood pressure, increase in cardiac output because of joint proprioceptor stimulation. Pain afferents, when you're in pain, again, a tachycardia is seen, right? This is because of, these are the factors which can affect the sympathetic discharge. Okay, Sneha, thank you. I'm taking a screenshot and I will keep this, I will keep your mnemonic with me and use it for my lectures. Thank you, Sneha. All right, CNS ischemic response. This is not to be seen in normal physiological range of blood pressure. When do we see a CNS ischemic response? When the mean arterial pressure is less than 65. This is not seen in the normal physiological range of blood pressure. Between 65 and 140, the cerebral blood flow is constant. There is no chance of any kind of ischemia. It's only when the mean arterial pressure is less than 65 that you get a CNS ischemic response. And what happens in CNS ischemic response? A massive increase in the sympathetic discharge, trying to restore the cerebral blood flow. Respiratory system, spirometry, volumes, definitions, extremely important. Has been asked in the NEET exam. Last 2 to 3 years, they've been asking this. What is the lung volume at the end of a maximum inspiration? Total lung capacity. What is the lung volume at the end of a normal expiration? Functional residual capacity. What is the lung volume at the end of a maximum expiration? Residual volume. What is the lung volume that is, sorry, this is total lung capacity. What is the lung volume at the end? What is the volume of air expired forcefully after a forceful inspiration? Forced vital capacity. Right? So this is what is the lung volume at the end of a maximum inspiration. That means it includes IRV, tidal volume, ERV, residual volume. That is going to be total lung capacity. Volume of air expired forcefully after a forceful inspiration, forced vital capacity. Right? All of these questions have been asked in the last 2 to 3 years. Right? Okay. And time vital capacity, you must know what is FEV1 by FVC ratio, what is the significance, obstructive, restrictive lung diseases. FEV1, volume of air expired forcefully at the end of 1 second, and you will normally express this as a ratio, FEV1 by FVC ratio, which is 0.7 to 0.8. Yes, obstructive lung disease, the ratio decreases. Restrictive lung disease, this ratio is normal to increased, right? And what cannot be measured by routine spirometry, residual volume, FRC, total lung capacity. What do you have for FRC? 3 techniques: helium dilution technique, nitrogen washout method, whole body plethysmography. Which is the one which is most accurate? Again, a question which has been asked. Plethysmography, whole body plethysmography, because this is the only technique by which you can also measure the air which is trapped in the emphysematous bulli. Right? This has been asked as a question. Then obstructive restrictive lung diseases, you should be absolutely familiar. Please remember, obstructive lung diseases, it is the rates which are going to be affected more than the volumes. Total lung capacity, residual volume, forced vital capacity, FEV1 by FVC, PEFR, MEFR. So rates are affected more than volumes. In restrictive lung disease, volumes are affected more than the rates. Obstructive lung disease, obstruction to flow. Restrictive lung disease, restriction in expansion. Obstructive lung disease, rates affected more than volumes. Restrictive lung disease, volumes affected more than the rates. Right? Flow volume curves, this has been done in medicine, but you should be able to also do this. I have done this in the DVT as well. Have a look at that. Flow volume curves, it's covered in medicine as well. Obstructive lung disease. This is restrictive lung disease, extraparenchymal due to chest wall deformities, and restrictive lung disease, parenchymal, right? Okay. The pressures which are responsible for ventilation, the first one is the intrapulmonary pressure from 0, -1, 0 at the end of inspiration, +1, 0 at the end of expiration. What about the intrapleural pressure from -2.5 it becomes -6 at the end of inspiration, back to -2.5 at the end of expiration. And what is the difference between these two pressures? This is known as the transpulmonary or the distending pressures. Right? So at least you must know that the intrapleural pressure is always negative. Less negative at the start of inspiration, more negative at the end of inspiration, back to less negative at the end of expiration. The only time the intrapleural pressure becomes positive is during a Valsalva. During a Valsalva, the intrapleural pressure becomes positive. And what is Valsalva? Forceful expiration against a closed glottis. Okay, the hysteresis loop. This is hysteresis loop. That is the compliance, lung compliance is more in expiration than inspiration. Why so? What happens in expiration? There is a decrease in the lung volume, increase in the concentration of surfactant molecules per unit area, which decreases the surface tension and increases the compliance. This gives rise to what is known as the hysteresis loop. Compliance more in expiration than in inspiration. With expiration, decrease in alveolar size increases the concentration of the surfactant molecules per unit area, causes a reduction in surface tension, more compliance. Absolutely right. Sandra's Bhashya, absolutely correct. Okay. Ventilation perfusion gradient, you have more perfusion, that is base to apex. There is a decrease in intrapleural pressure. Intrapleural pressure is less negative at base, more negative at the apex. Base to apex, there is a decrease in ventilation. Ventilation more at base, less at apex. Base to apex, decrease in perfusion. Perfusion more at base, less at apex. Right? More at base, less at apex, but the VQ ratio increases from base to apex. VQ ratio increases from base to apex. So remember this as far as your gradients are concerned, right? That is base to apex decrease in intrapleural pressure, ventilation perfusion, but VQ ratio increases from base to apex. Takes care of a lot of questions asked on the VQ gradient. Respiratory exchange. Now, this is again extremely important, especially physiological shunting. When I look at the atmosphere, the partial pressure of oxygen in the atmosphere is 160 millimeters of mercury. The partial pressure of CO2 in the atmosphere is 0. When I inspire, after humidification takes place, the PO2 reduces to 150, PCO2 is still 0. Remember, the only source of CO2 is from the alveoli. But by the time the air reaches into the alveolus, this is humidified, inspired air. Right? By the time it reaches into the alveolus, the partial pressure of oxygen in the alveolus is 100. PCO2 will now be 40 in the alveolus. Yes, PCO2 will be 40 because where does the CO2 come from in the alveolus? From the blood. So this will equilibrate by the CO2 in the arterial blood. Importantly, when you look at the alveolus, like I said, PO2 is 100. When blood comes from the venous side, the PO2 is 40. When the blood leaves the arterial side of the capillary, PO2 increases to 100. But when I take a sample from the systemic arteries, the PO2 has reduced to 95. And the reason for that is the physiological shunting. Physiological shunting. What is physiological shunting? A part of the venous blood from the bronchial circulation, from the coronary circulation, drains directly into the left atrium. That causes the PO2 of the arterial blood to reduce to 95. That is called venous admixture of blood. This is called a physiological shunting. Remember, because of physiological shunting, there is an AaO2 gradient. AaO2 gradient, alveolo-arterial oxygen gradient, which is usually 5 millimeters of mercury, but the range can be between 5 to 15 millimeters of mercury. Range can be between 5 to 15 millimeters of mercury. Usually 5. This is because of physiological shunting. What will happen? This was asked as a question. What will happen to the alveolo-arterial oxygen gradient in high altitude? Unchanged. What is going to increase this alveolo-arterial oxygen gradient? If there is a problem with diffusion, if there is a pulmonary fibrosis, if there is a pulmonary edema, if there is a VQ mismatch, right? If there is a right to left shunt, that will cause an increase in alveolo-arterial oxygen gradient. But in high altitude, there will be no change in the alveolo-arterial oxygen gradient. So herein comes all your clinical and applied part. Oxygen content, we must be absolutely familiar with oxygen content. How do you do the oxygen content? This is oxygen in combination with hemoglobin. Oxygen in combination with hemoglobin plus the dissolved oxygen. Right? And how do you see oxygen in combination with hemoglobin? Take the hemoglobin in grams per deciliter into 1.34 into the percentage saturation. And how do you see the dissolved oxygen? Take the PO2 in millimeters of mercury and multiply it by the solubility. What is the solubility? 0.003 ml per 100 ml per millimeter of mercury pressure. This is the oxygen. Please remember, oxygen content means oxygen in combination with hemoglobin plus the dissolved oxygen. Oxygen in combination with hemoglobin in grams into 1.34 into the percentage saturation of oxygen. Dissolved oxygen, take the PO2, multiply it by 0.003. This will give you the oxygen content. And once you see this, 99.9% of the oxygen is in combination with hemoglobin. This is the major vehicle for transport of oxygen to the tissues. PO2, the dissolved oxygen, is just a fraction of the total. But this PO2 is not insignificant, because PO2 will determine the saturation. PO2 and saturation are linked with each other via the oxygen-hemoglobin dissociation curve. PO2 will determine how much will be the hemoglobin saturation. That is why PO2 is important. So you must know why is it a sigmoid-shaped curve? What are the conditions? What is P50? P50 is the partial pressure at which hemoglobin is 50% saturated. Normal value 25 to 27. What will cause a shift of the curve to the right? What will cause a shift of the curve to the left? Important questions. So many times they have been asked. Neural control of respiration, you've got the medulla, which has, if I look at this is the medulla here, which is the spinal cord, the medulla, which has got the respiratory center. Respiratory center means pacemaker, pre-Botzinger complex, plus dorsal respiratory group of neurons, plus the ventral respiratory group of neurons. Then the pontine center's lower pons is apneustic center, which stimulates the depth of inspiration, pneumotaxic center, which inhibits the depth of inspiration. And you've got the higher centers, which includes the cortex, which can include the limbic system, which can send impulses and modify the rate and depth of respiration. Right? Pontine centers, the role of the pontine centers is a smooth transition, as well as smooth transition between inspiration and expiration, as well as they control the depth of inspiration. How do they control the depth of inspiration? Please remember, the primary effect is not on the rate, but on the depth. Pneumotaxic center inhibits it, apneustic center strongly excites the depth. Yes, strongly excites the depth. Important applied part is Ondine's curse, which is also called the central hypoventilation, congenital central hypoventilation syndrome. Right? And what happens in Ondine's curse or central hypoventilation syndrome, congenital central hypoventilation syndrome? Here, voluntary control is present, but involuntary control is lost. Voluntary control is present, but involuntary control is lost. So as long as this patient is awake, he can breathe, but the moment he goes off to sleep, he stops breathing and will obviously die. That is Ondine's curse, or this congenital central hypoventilation syndrome. Chemical control is with the help of chemoreceptors. Two types of chemoreceptors, the peripheral and the central chemoreceptors. What are the stimuli for the peripheral chemoreceptors? Hypoxia, increase in CO2, increase in H+, decrease in pH, increase in lactic acid, increase in K+, and cyanide. Central chemoreceptors, most potent direct stimulus H+, but from the blood, CO2. Right? CO2, remember, can act on both peripheral as well as central chemoreceptors, but mainly on the central. And chemoreceptors, whenever they are excited, they will increase the rate and they will also increase the depth of ventilation. They will increase both the rate as well as the depth of ventilation. This is the chemoreceptors. Remember, hypoxia can only affect peripheral chemoreceptors. Increase in CO2 will affect both peripheral and central chemoreceptors. Both peripheral and central chemoreceptors. Right? This is as far as your chemoreceptors is concerned. Let's have a look at some important topics in CNS. Now, as far as CNS is concerned, the ascending tracts, you've got the posterior columns, the lateral spinothalamic, the spinocerebellar tracts. Important point, what are the sensations carried by the different tracts? Dorsal columns, fine touch, localization, vibration, 2-point discrimination, conscious proprioception, stereognosis, ability to judge different degrees of pressure. Lateral spinothalamic tract, pain and temperature. Anterior spinothalamic tract, crude touch, itch, tickle, barognosis, detection of pressure by anterior spinothalamic, but the ability to judge different degrees of pressure by the dorsal columns. Spinocerebellar tracts for unconscious proprioception. From the lower limbs, you've got the dorsal spinocerebellar and the ventral spinocerebellar. From the upper limbs, cuneo-cerebellar and the rostral spinocerebellar. Right? Rostral spinocerebellar. Now, important point as far as the spinocerebellar tracts are concerned, all the tracts go to the same side cerebellum. The dorsal tract and the cuneo-cerebellar tract, they are uncrossed. They do not cross, they go to the same side cerebellum. The ventral spinocerebellar and the rostral spinocerebellar cross twice, ending in the same side cerebellum. They do cross, but they cross twice. So they end on, say, all these four spinocerebellar tracts end on the same side cerebellum. Absolutely right, Dr. Knight. Highway, fast pathways. These are dorsal columns. These are the ones which have come later in evolution. These are the lateral spinothalamic and anterior spinothalamic tract. They came much earlier in evolution. They carry cruder sensations. Dorsal column, medial lemniscal pathway will carry finer sensations. You must know where is the first order sensory neuron. Please remember, crossing in the case of the dorsal column will occur at the level of medulla. It is done by the second order sensory neuron. In the spinothalamic tracts, a second order sensory neuron will cross over to the opposite side, but at the level of entry or 1 or 2 levels above. Right? Please remember, first synapse for posterior column is at the level of the medulla. First synapse in the case of the spinothalamic tract is in the dorsal horn itself at the level of entry into the spinal cord or 1 to 2 levels above. Right? And ultimately they will terminate in the primary somatosensory cortex. Yes? You should know the arrangement of fibers in the posterior column from medial to lateral, sacral, lumbar, thoracic, cervical. In the case of the spinothalamic, it's a lateral to medial arrangement, sacral, lumbar, thoracic, cervical. Right? Akshi, just see this please. It is a crossed tract, Akshi. It is a crossed tract but crosses twice. It is a crossed tract, it is crosses twice. That is why ultimately, see there's a difference here. Slight difference here, Akshi. Ventral and the rostral spinocerebellar will cross twice, so ultimately end up on the same side cerebellum. Have you understood? They cross twice, so end up. So basically, the point I'm trying to make is all four will end on the same side cerebellum. Okay? Akshi, is that okay? Okay. All right. So this is as far as the arrangement of fibers. Medial to lateral, sacral, lumbar, thoracic, cervical, lateral to medial for the spinothalamic tracts. Important clinical application: if there is a medullary spinal tumor, the loss of pain will be from cervical. It will be a descending sensory loss. But if it's an extramedullary spinal tumor, it will be an ascending sensory loss. Right? Ascending sensory loss. Okay? Okay. Of course, the sensory cortex, the sensory homunculus, and important point, you have the representation of the leg on the medial side. Leg, foot, toes is on the medial side. In fact, the genitals are also represented below the toes. So genitals are also over here, right? Very large area for the face, including lips. Very large area for hands and fingers. Okay? Okay. Descending tracts, you've got medial and lateral descending tracts. Sneha, if you have, Prithviraj, decorticate, decerebrate, I'll put up a little small video. Okay? I'll put up a small video. You can just let me know. I'll put up a small video regarding the decerebrate, decorticate. Okay? Okay. All right. So descending tracts, you've got medial and lateral descending tracts. Lateral descending tracts for the control of distal muscles, medial for proximal muscles and tone and posture, lateral for fine skilled movement. Most important tract for fine skilled movement, the lateral corticospinal tract or the pyramidal tract. Yes, pyramidal tract. Medial descending tracts are meant for control of tone and posture. The lateral corticospinal tract and rubrospinal tract, they supply the A alpha, especially of the upper limb flexors, because it is the upper limb flexors which are responsible for fine skilled movement. Anterior corticospinal, vestibulospinal, tectospinal, they supply the A alpha, especially of the lower limb extensors. These are involved in tone and posture. Reticulospinal tract will supply the A gamma. Reticulospinal tract, A gamma, especially of the lower limb extensors. And what are the A gamma fibers? A gamma fibers are the motor fibers to the muscle spindle. A gamma fibers are not responsible for muscle contraction. They are responsible for muscle tone. Right? Okay. So the origin of the tract, where does this come from? The 60% of the fibers will come from primary motor cortex, premotor and supplementary motor areas. 40% come from the sensory cortex. But please remember, from the sensory cortex, there's motor fibers, not sensory fibers, right? And these fibers descend downwards, pass through the internal capsule, reach the medulla. In the medulla, 80% of the fibers will cross over to the opposite side, form the lateral corticospinal tract. The 20% of the fibers which do not cross form the anterior corticospinal tract. At the level of the medulla, you have the formation of pyramids. 80% of the fibers which are crossing will form a bulge which is seen on the anterior surface, which is known as pyramids. And that is why the lateral corticospinal tract is known as the pyramidal tract. The motor homunculus, very largest representation is for muscles of vocalization. Second largest is for the muscles of mastication. And the third largest is for the muscles of the thumb. Right? Muscles of the thumb. Okay. Stretch reflex, inverse stretch reflex. Stretch reflex, stimulus, increase in muscle length, receptor, muscle spindle, afferent fibers 1A and 2, center spinal cord, A alpha, efferent, response, muscle contraction, monosynaptic reflex. Extremely important slide. Lot of questions regarding stretch reflex, inverse stretch reflex. You can be asked, what is the afferent to the muscle, what are the afferent fibers from the muscle spindle 1A and 2? What is the efferent of the stretch reflex? A alpha. What is efferent to muscle spindle? That is a separate question altogether. That is A gamma. That's a separate question altogether. So do not get confused. If you're asked a question, efferent of stretch reflex A alpha, efferent to muscle spindle A gamma. Inverse stretch reflex is a bisynaptic reflex. Here the receptor is a Golgi tendon organ. Afferent 1B, center spinal cord. Efferent is again A alpha, but this A alpha is inhibited, producing a muscle relaxation. Cerebellum, 3 parts. These 3 parts, functions of the 3 parts have been asked very, very often. Floccular nodular lobe, meant for balance and eye movement. Spinocerebellum for coordination. Lateral part of the cerebellar hemispheres, or the cerebrocerebellum, is meant for motor planning. Spinocerebellum, the part in the midline, this part here is meant for control and coordination of axial muscles. The lateral parts are meant for control and coordination of distal muscles. Yes, cells of the cerebellum, which is the only excitatory neuron, the granule cells. All the others are inhibitory. Yes, again, an important question. You should know what is the output of the cerebellar cortex. Output of the cerebellar cortex is from the Purkinje cells. Purkinje cell will project to the deep nuclei. Again, a question which has been asked again and again. The Purkinje cells project to deep nuclei. Output of cerebellum is from deep nuclei. Deep nuclei output is excitatory. Purkinje cells, which are inhibitory neuron, will modify the excitatory output of the deep nuclei. Input is via climbing fibers and mossy fibers. Climbing fibers, strong excitatory input formed by olivocerebellar tract. Yes. Divya, please understand 2 important questions. Efferent of the stretch, efferent arm or efferent fibers of the stretch reflex, A alpha. Efferent to the muscle spindle, that means motor fibers to the muscle spindle, are A gamma. 2 different questions, different answers. Do not get confused just because the term efferent is being used. Efferent of stretch reflex, A alpha. Efferent to muscle spindle, A gamma. Okay? Okay. Basal ganglia, caudate nucleus and putamen, called the striatum. Sorry. Caudate nucleus and putamen, together known as the striatum, which is mainly GABAergic. Globus pallidus external segment, GABAergic. Globus pallidus internal segment, GABAergic. Substantia nigra. Substantia nigra, pars reticularis secretes GABA, but pars compacta secretes dopamine. And the only excitatory, the only part of the basal ganglia secreting an excitatory neurotransmitter is the subthalamic nucleus of Lewis, which secretes glutamate. Right? Glutamate. Nishat, just winding up almost towards the end. Right? Okay. You must, again, important as far as the NEET exam is concerned, is the nuclei of hypothalamus. You have this in your notes. This is just a little chart which is showing you the same thing, right? Which are the parts of the hypothalamus involved in temperature regulation? Which are the parts? What is the hunger center, satiety center, thirst center, rage center, reward center, circadian rhythm, sexual behavior? Which are the neuroendocrine? Which are the hormones which undergo a neurosecretion? Yes, and endocrine control. So these are your nuclei of hypothalamus, extremely important as far as our NEET exam goes. Hypothalamus, the neurotransmitters which are involved in sleep. Yes, during sleep there is increase in GABA, decrease in histamine. Remember, antihistaminics are sedatic. In NREM sleep, there is increase in GABA and decrease in sleep. Right? And right. A couple of topics from GI tract, and then we'll wind up. BER, basal electrical rhythm generated by the interstitial cells of Kajal. What is this basic electrical rhythm? This is a variation in the membrane potential. This is the BER. This is not responsible for contraction. What is responsible for contraction are the spike potentials which are superimposed on the BER. See this, when acetylcholine causes an increase in the frequency of the spike potential. It does not affect the BER. Acetylcholine will increase the frequency of spike potential and increase the muscle contraction. Epinephrine, sympathetic stimulation for the GI tract, decreases the frequency of spike potential without affecting the frequency of BER. Remember, acetylcholine and epinephrine are affecting the spike potentials, not the BER. And therefore, if they are affecting the spike potentials, they will affect the strength of muscle contraction. They will affect the muscle tone and the muscle contraction. Okay? BER, maximum frequency duodenum, minimum frequency cecum. Right? Amplitude of BER, 5 to 15 millivolts. Must remember the hormones and their actions, again, extremely important from the NEET point of view. Gastrin increases HCl secretion. Gastrin will increase the HCl secretion. Ghrelin increases appetite. CCK is a cholagogue. Secretin will cause an increase in the bicarbonate content of bile and pancreatic juice. This is also known as a hydrocholeretic. There are two incretins. Which are the two incretins? Incretins are GI hormones which increase the insulin secretion, but that is GIP and GLP-1. But which is the most important hormone which increases GI hormone which increases insulin secretion is GLP-1, more important than GIP. GLP-1 is also known as the physiologic beta cell stimulating hormone of the GI tract. Somatostatin will decrease the motility of the stomach as well as the intestine and also decrease the secretory activity. Motilin will increase the gut motility and is responsible for the migrating motor complexes. Right? Okay. Salivary secretion, the maximum volume gastric, minimum pH will be for gastric, maximum pH will be Brunner's gland, that is most alkaline is Brunner's gland, and number 2 is pancreatic secretion. So again, important questions. Okay? All right. This is as far as your the important topics are concerned. Yes, I will put up a PDF as far as I'll put up PDF as far as these topics which we have discussed is concerned, right? Jay Kritibhai Bhatt, renal, as far as renal is concerned, GFR, important. What are the factors affecting GFR? You must know the net filtration pressure. What is PGC, PyGC, what is PBC and PyBC, so net filtration pressure. Second important point as far as kidney is concerned is clearance, formula for clearance, UV by P, urinary concentration into rate of urine flow divided by plasma concentration. Number 3, absorption of the handling of different substances, sodium freely filtered, maximum reabsorption in the PCT. Yes, it is in fact reabsorbed in all parts of the nephron except the descending thin segment. Yes, I thought kidney would be relatively easy, so I didn't think about revising the kidney topics with you. Endocrine, there is an overlap with medicine, so I thought it's not, we have limited time. I had these 45 minutes. I wanted to concentrate more on the CVS, RESPI and CNS. Right? So this is what I wanted to concentrate on. As far as kidney is concerned, one more point about glucose reabsorption only in the PCT. Potassium is the only ion which is both reabsorbed and secreted. Calcium, 99% is going to be reabsorbed. Magnesium, maximum reabsorption in the thick ascending limb. So simple one-liners which could be asked. Unlikely, but could be asked also. Right? And okay, sensory receptors, Rohan, yes, as one-liners were important more from a one-liner point of view, but I do not expect too much to be asked from sensory receptors in this year's NEET. Yes, okay. Thank you so much and God bless, and please revise your class notes, go through your class notes. I tried to bring out all the important topics in this session, short session, but yes, of course, I will give you the PDF. Please don't worry about it. I will put up all the points discussed, and I'll put them in a better handwriting than what you saw in class. Yes, the class, of course, what you saw in this 1 hour, I had to go fast. So obviously the handwriting would not have been satisfactory, but in the PDF, I'll make sure that it is written. No, it cannot be, all right. Yes, thank you so much, and God bless Archana. Thank you, Anurima, Sudarshan. Thank you so much. Revise, revise, revise. That's my last 3 words to you. That's the only way to max this exam, only way to do well in this exam. Please go through all that you have learned. Don't just go through again and again, as many times as possible. That's the only way to do well. Thank you so much, and God bless. Thank you so much. Thank you. Thank you. Yes, thank you, El Reddy. Thank you so much. Yes, I will give you a marked PDF. Absolutely, I will put it in my own writing. Okay. Okay. Thank you so much. Thank you. All right. Thank you so much. Thank you. Thank you so much for your responses. Thank you. God bless. Thank you so much.